Welcome. This is Bridges and Muyi Aina. As we build a sustainable environment for growth. The health sector in the country is undergoing massive reforms and is determined to give quality healthcare to all Nigerians at every level. While we commend this evolution, and we also know that it is important because it's the steps that are needed to achieve universal health coverage. Now, primary health care undergirds healthcare for all, especially at the grassroots level where it matters, where majority of Nigerians reside, where they must have access to health, there must be supply and demand. So we're talking about supply and demand, particularly at that level. We must make demands for health services because health is a human right. And that's why the coordinating health minister himself for health and social welfare is driving this and recently issued a red letter. Yes, if you don't have it yet, you can Google it and read through it. And the action is to envision and galvanize the supply and accountability and also improve delivery service. But the way to start, according to experts, is getting it right at the primary healthcare level. And so today, to give us further insight into what is being done, to ensure that primary healthcare lives up to the expectations of Nigerians. We have here with us the Executive Director of the National Primary Healthcare Development Agency, NPHCDA, one and only Dr. Muyi Aina. Dr. Muyi, you're welcome again on Bridges.
Good morning, Auntie Moji. Always a pleasure to be here.
Right. So we're going to, what we intend to do in the next half an hour is to see how far or what primary healthcare is doing in terms of reforms and revitalization, and of course within the context of the new red letter alert. So let's start with you. How is National Primary Healthcare Development Agency aligning its primary healthcare revitalization agenda with state governments? Because it's not just about you. It's cascading to the sub-national that we can get it right. So what are you doing?
Thank you, Auntie Moji. You will recollect that at the beginning of all of this, in 2023, President Bola Ahmed Tinubu had instituted the Health Sector Renewal Investment Initiative and in fact signed a compact with the state governors. It was appended by the state governors, by the development partners, and even the civil society. Now there are plans to add the local governments to that as well. And the minister started to lead the execution of that, coordinating minister party, taking an approach that we call the SWAP, the sector-wide approach. And what this does is to galvanize every level of government around the same set of priorities, to make sure that we're at the same table having the same conversation, to make sure that there's an integrated plan, what we call one plan, so that every state feeds their plan into the national plan. So we're all moving in the same direction, because it's not as though there wasn't work being done before now, but it was fragmented, it was disorganized, people were moving in different directions. And while some of the traction and progress we have seen recently has certainly been due to increased funding, increased effort, increased focus, I think that ability to coordinate better has allowed us to start to get more value out of the resources that we have. So in a couple of weeks, we will be having the joint annual reviews, which is bringing all of the states together with the federal government, with our partners, to say, okay, over the last year, since the first jar that we did last year, where are we? Where have we seen progress? Where are we stalling a little bit or moving too slowly that we need to adjust? So those kinds of mechanisms are what is really galvanizing the interest and support and movement in one direction now in the primary healthcare system.
Fantastic. So primary healthcare, it's germane to this. I mean, getting it right at that level. What has been your experience?
I think, look, what is clear is that if we're going to get universal health coverage right in this country, primary healthcare is the entry way to that. And fortunately, we have a government from the top, very top, that recognizes that and so has prioritized and is focusing on really improving the access, the quality and equity of primary health care.
So it would be right to say there's political will.
There is political will.
Okay.
There is political will at the highest level. There is political will more and more, even at the subnational level, because of the elements that I spoke about before, the sector-wide approach. The governors are beginning to see the impact of what we're doing, and I think we're also fortunate. I've been around the sector for a little bit. I don't remember a time when there was as much consensus around let's invest in primary healthcare and make it work.
Okay. Well, as much as funding and expansion have occurred, we still have one of the pillars of the primary healthcare is prevention, and then you speak to immunization. Sadly, we still have millions of children who, have zero dose or who would consider under-immunized out there. What exactly are you doing? Because if we can, experts say if we can tackle prevention, then more and more lives will be saved.
Yes. There are a number of things that we're doing, but just to take a minute to step back and say, how did we figure out, what you need to do? I think what we observed was because of a long-term chronic underfunding of the system. The system, primary healthcare system, but even the health system broadly, failed Nigerians in many ways before now, if we're going to be honest. People will go to the facilities and they didn't necessarily get what they wanted to see. We're still not at a point where we can guarantee you that everywhere you go now, every facility can give you everything you need. But we started to rebuild that trust. So we, using increased funding that the President has approved for us and is coming in form of one basic healthcare provision fund, which is now, the minister announced in his letter, the
32.9 billion naira
that will go to health facilities through 4 gateways. Actually, will go downstream through 4 gateways. Just under half of it, 45%, is what comes through the National Primary Healthcare Development Agency gateway and will go on to the states and the local government and the health facilities. Outside of that, we have also spent a bit of resources and are working on that to improve the quality of the health facilities, to improve the number and quality of staffing in terms of hiring more. We're working with the states now. You asked about how we're aligning with the states to hire what we call skilled birth attendants, nurses, midwives, doctors, to hire community-based health workers. 8 states have hired now. Very unprecedented. It used to be that it was always a hassle, but through a collaboration, and engagement, that is happening that way. For immunization that you asked specifically, yes, Nigeria does have a disproportionate burden of zero-dose children, but we have again tackled that head-on by identifying those locations where the zero-dose children are, and it's not necessarily because they are bad people or they don't want the vaccines, but they are disadvantaged in many ways, hard to reach areas, little information, little education. So vulnerability tends to overlap themselves across many, and we're trying to tackle them, in many ways. So the first thing we did was to even try to say who are these children and where are they. So we started to enumerate them and line list them, and then follow each one of them one by one. And every time we intervene, we go and actually track. We're doing a nationwide integrated campaign now that includes the measles rubella vaccine, the polio vaccine, the human papilloma virus, all routine vaccines basically, and some nutrition, even malaria intervention, and neglected tropical diseases in Kano State, for example, where they still have a bit of a burden. So what we found through that intervention is that, we started tracking children that were zero dose, and 67,000 children already that had not received any vaccine have now been reached with the first dose of penta vaccine, because we're very deliberate and looking for them and tracking them and measuring them. And we wouldn't stop that, even outside of campaigns, through routine outreaches, through special interventions. For example, in areas that have security challenges, we work with the states in Northeast, Northwest, and some North Central states now, to do what is called REST, reaching every settlement, where we work with paramilitary, sometimes even military personnel, to go into locations, find children, and give them integrated packages of care, not just vaccines, but other felt needs. Because one of the problems that the vaccination program has experienced is that people wonder why we push vaccines so much when they also have other needs, malaria, they're hungry, they have to go and buy all of those things. Of course, the government cannot solve everything for everybody at the same time, but at least we are now being more responsive to their people's needs and trying to have a more integrated package that at least starts to address some of the perceived needs of the populations that we're trying to serve.
Okay, we have the red letter that is trending, and so we asked some of our viewers that now let's have your views, and I'm just going to read verbatim some of the one of the questions that actually we got, which we thought we can share on this program. How can citizens monitor primary healthcare projects and verify if funds and supplies truly reach their local health facilities? This is against the background of the Honorable Minister issuing this red letter. Would like to ask if the fund disbursed per facility is available publicly, like maybe on your website.
I think this is a very fair question, and one of the tenets of Minister Pati's leadership is transparency and citizen engagement. Since we have started, and many Nigerians may not be aware of this, but now thanks to the red letter and the publicity that it has generated, I think more people will be aware. Every time this money is disbursed, it's actually published in the newspapers, what goes to each state. Now, but what we are going to in fact do is, following the announcement last week at the Ministerial Oversight Committee, we're now in the process of disbursement. So the money for this quarter hasn't actually reached the facilities yet. Again, it will be split between the gateways. That information will again be published, and we will make it very public when it is published. But beyond that, there are other mechanisms that Nigerians can use. For the primary healthcare centers, for example, we have a dashboard, the PHC dashboard, where for over 26,000 primary health centers that are functional, providing services in this country today, people can go to phc.nphcda.gov.ng. There is a live dashboard where you can zero it down to your location. You can select the ones that are basic healthcare provision fund, BHCPF, if you want to know which ones are receiving the money. You can select around your location, and you can go there, and the facility in charge, the head of the facility, their name and their phone numbers are there. We encourage Nigerians to not bother them unduly and distract them from the work, but you can ask questions. You can go there, to see. And I want to also say that it's one thing to verify that the money got to the facility. That's very easy. Bank, we verify that all the time because of bank statements and transfers. It's digital. What is even more important is that Nigerians pay attention to what the facilities are spending the money on. Is somebody taking out the money from the bank and using it for personal interest, versus are they buying the medications and the supplies in the facility, and that? I think that is even more important and more useful. It's easy to know who sent money to where. That's a bank transaction. It's digital. But when people start to make last mile transactions, I want to pay for motorcycle transportation, I want to pay for this, I want to pay for that, it's a bit more difficult for us to sit in the center and track that. We've put mechanisms in place. We have performance and financial management officers in every local government. We have health fellows in every local government. And we are also now rolling out a digital tool that is an accounting app that every facility has to report what they are spending, and we will track and verify. Eventually, this will be linked to their bank accounts so that you can see where they are actually transferring the monies. And that's the direction that we're going.
Wonderful, especially in the digital world. It's important to apply what works. Now, Nigeria still has one of the highest maternal and child mortality. You know, when we rate us globally. Now, what is new that the primary health care level? What kind of strategies been deployed to change this, considering the fact that you know, many innovations such as the PPH bundle, handheld ultrasounds, etc., are now available. How are you able to deploy that at primary healthcare level?
Yes, there are multiple prongs of approaches that were taken. I think it's important to say that maternal mortality is a priority for all of us, not just the primary healthcare level. So we're working with secondary, with tertiary level. And the coordinated minister sits at the helm of an intervention called the Maternal Mortality Reduction Innovations Initiative. And what that really does is we have identified local government areas, 172 of them, that account for the most, at least with the data that we have. Everywhere, women die everywhere, and that's not acceptable, but you have to start somewhere. So we started with the 172 local governments in 33 states of the country that have reported the largest numbers of maternal deaths. Between them, they account for more than half, 55% of all deaths. And what we're doing there is trying to find every pregnant woman and, in fact, support them through pregnancy. The reasons women die are that when they need to get an ultrasound, they don't get one. When they need to check their blood, their blood test, or get their urine tested to see whether there are situations that require more advanced care, we don't do that. And when they need to get to a facility quickly because they're in labor, sometimes they don't have access to. When they need to be referred, you know, and the newborns as well. You know, it's also one thing to keep the mother safe, but also the ability to resuscitate and support newborns so that they live, you know, and survive is also important. So the MAMI program is really doing that. It's now active in 32 states at different phases. There's one state where we're just going to start, and that is Rivers, because we were going through a transition in Rivers, as you are aware. But all of the other states have activated, and we are working with them. Some of the innovations that you talked about are being provided directly by the federal government, ultrasound machines. So as part of our PHC revitalization, we have procured for 500 PHCs, for example, that are there. But the states are also buying more. Again, I told you that they are now aligned and really helping to drive this, because it's about their people, literally. It's the responsibility of the states and the local governments. The federal government is merely supporting them. But the states are, in many instances, actually stepping up to take this leadership, and we're very encouraged about that. The PPH bundle, we have rolled out in 10 states now, you know, and we now have a line of sight, a plan, you know, to expand to the rest of the states. We've been doing the fundraising for that. So we're making progress in terms of the elements, and what you see is that Nigerians are starting to see that, because the utilization of services in the health facilities is going up. In the second quarter of this year, for example, we had over 14 million service contacts, which means people who went to the facilities. Not 40 million individuals, but some people go twice, thrice in a quarter. But that's more than twice what we had even 2 years ago, you know. So that means people are seeing it, people are starting to access this care. So then we collectively have an obligation that as people are now, as the trust is being rebuilt, we need to not let the people down. We need to make sure
Of course, that will also upscale demand.
Yes.
So,
yes.
Well, it's a whole gamut of what should happen. We're looking at human resource availability of that. And well, you deal with primary health care. What kind of human resources are at that level that can actually man the revitalization that you're speaking to?
So when we defined what we want every facility to be, we took into cognizance our realities and the shortages in manpower that we have in health sector. And we said at a minimum, for a facility to operate 24 hours, you need 6 healthcare workers that can take deliveries, or 4 if there is accommodation, because then they can take shifts, they can sleep overnight, and when the patient comes, they can attend to them. So as part of our definition for level 2, we are requiring a minimum of 4 skilled birth attendants. And those are midwives, they are community health workers that have been upskilled to take deliveries. So they are kind of community midwives, very few instances in the more urban areas, doctors, In addition to that, they have other staff, pharmacy technicians, lab technicians, and all. But those that can actually take deliveries in a way that keeps the woman alive and keeps the baby safe. I think those are those categories. And we are seeing improvements. The states are hiring more. We're supporting them with some time-limited salary support as an incentive. Project Hope also has incentives for states to hire the staff and train them. We're also training, by the way. We're doing lots of training. We've trained over 70,000 now in the skills that they need, to provide primary health care
to mitigate some of these problems. Okay. What would you be saying to Nigerians?
I think a number of things. One is that the journey of transformation of the primary healthcare system is in fact a journey, and it has started. And I think many Nigerians can testify to that. We want Nigerians to own that, to be part of that. As government officials, we're only going to be here for a while. There will be, all of us will do our time and go away. But Nigerians will be here. In fact, we will become Nigerians and citizens. Let everybody engage in the primary health center that is in their community, Go there, help them out. You don't have to be a health worker. But even when they know that people care and people are involved, the health workers, they will not only be encouraged, they will also be on their toes, because they now know that information can go around on what they are doing. Make sure people are doing things right. Don't bully them, don't harass them, or recognize the challenges and recognize the environment that they're working in, but hold us accountable. And also contribute, participate. The primary health care is a communal effort. It's all of us. It's not just the people working in the health sector formally, but everybody. Health promotion, when you tell your neighbor, go and vaccinate your child, that is primary health care. When you tell a pregnant woman near you,
go to ANC.
Have you attended ANC? That is primary health care. And that is what I am telling Nigerians that we need for all of us to advance in our primary health care.
Well, but since we are so dependent on government in terms of, particularly in the health sector, I would want to ask this final question. If you have 1 minute, and which I think you have, how would you convince state governors to invest in primary health care? What would you be telling them? What has been your advocacy message?
I think every leader ultimately wants to be remembered as a success. And at the center of leadership is bringing people out of poverty, And if you are going to bring people out of poverty, you have to focus on human capital development. So healthcare is at the core of that, because a healthy nation, they say, is a wealthy nation. So a healthy state, by extension, is a wealthy state. When you have a healthy young population, they are able to be more productive. You also minimize the incidence of catastrophic health expenses. A strong primary health care system prevents more advanced complications that make people go into health expenses that turn them into poverty. So this is something that touches people directly, even politically. It's very beneficial, and I think a lot of governors see that, which is that when you invest in the healthcare, people see it, it touches them directly, So that investment is money well spent, and we thank the governors for what they're doing, and we appreciate them and ask that they do more. We still have a very long way to go together. Thank you.
I'll take it from there, to do more. I like the fact that it is all encompassing. It's not just about the doctor or the nurse or the sick. It's about you, in the first instance, preventing to be ill, and being able to be there for that pregnant woman who needs it. And it's a collective responsibility going forward. The road transport owners who should also galvanize themselves to be part of this. The media, as it were, should also be able to be part of this. And everyone should be part of that. Because the experts are saying, and we know, it is only a healthy person that can live a fulfilling life. And so we do hope we'll bring you back again, Dr. Aina. Thank you for coming on Bridges. So to build and protect the health of Nigerians is a call to action by everyone for everyone. Thank you for watching Bridges, this special edition. We'll be back again. Stay healthy, eat healthy, clean your environment, and that way we can build the Nigeria of our dream. We're back again, same time next week. Thanks for watching.